However, when we have common resources, they are neither excludable not neither excludable, they are not excludable, but there is a rivalry in consumption. And because of these characteristics, there is a tragedy of commons. There is tragedy of commons. Commons come from the common resources. What is this tragedy of commons? That when common resources, this appear when common resources are used more than desirable amount. Say the park, right? So the park, if there is no entry fee, so it's not excludable. At the same time, the rivalry in consumption, in terms of the rivalry in consumption, there is a rivalry in consumption because it is in high demand and a lot of people are entering the park to have their morning walk, or a hospital, a government hospital, so there is a serious rivalry in consumption. But then the tragedy of the commons occur, because this tragedy of commons do not occur at the very first level when the commodity or the service is a public good, because then there is no rivalry in consumption. But looking at that, there is no entry fee, there is no cost associated, no price associated, so people get interested, and if it gives a nice benefit, people get interested, and then they start using more and more and more and more and more, and then it develops a rivalry in consumption. The moment there is a rivalry in consumption, then the system is utilized more than it is desired, and then the system cannot or may not work on the most efficient manner. That is what we see happening in the government hospitals, that as there is a heavy footfall as compared to its what it can generally take or it is supposed to take. Naturally the number of the people who do not have beds or who do not get treatment for a longer period of time increases, right? And that is the tragedy of common. And however, what happens is some social and private incentives can work out. That how the social and private incentives work out. This is because, say, now to decrease the load from that hospital, the government can decide to rope in some private hospitals. Yes, the government extends some, say, tax benefit to them, or some subsidies are offered. But what happens, this actually takes the load out of these government hospitals, and many people under a particular scheme can also take benefits from some private hospitals. And it has been found in this Yashaswini scheme and also Vajpayee Arogya scheme in Karnataka, that there are several non-governmental organizations or private organizations which have joined with the government and extends the benefit or the cashless benefit under that particular scheme, which has been floated by the government, as does the government hospitals or has to the government hospitals. So these social and private benefits offered or incentives offered may help this tragedy and commons. Otherwise, and it can result into a negative externality. It started with a positive externality, but it can result into a negative externality, because if I don't have any cost as such, but my benefit is decreasing and decreasing, and then the the park administrator or the hospital administrator decides to increase some user fee or entry fee, introduce some entry fee, which increases the cost overall for the patients or the the morning walkers, but it doesn't really decrease the load. So there is so the cost increases and then the benefit really doesn't increase or doesn't change much. In fact, it can go down with and because from our no excludability, the excludability cannot be suddenly brought in a large extent. So it's a slow process, and it may not be possible in most of the cases, especially in terms of healthcare. Therefore, there is a this negative externality may be there in case of a common resource, and then a tragedy of commons, with a negative externality in case of both the production and consumption. However, when we talk about the the negative externality, is we are talking about mostly the opportunity cost, because here nobody is paying a cost user fee initially, and the cost is in terms of if I don't get a bed, but my patient or I personally deserve a bed, and then not having bed, I am not probably getting the best of the treatment, and then the overutilization of the system is actually diminishing my satisfaction, or it's my what I must require, or I must have, and it's actually decreasing the efficient productivity or efficient health outcome or health services, or improves my health status, what it should have been. So naturally there is a negative externality. So the cost and the benefit in terms of the negative externality is not probably or not mostly the cost component estimated in terms of a direct cost, but mostly in terms of an indirect cost, as well as this opportunity cost or sunk costs. Anyways, and that's primarily because the common resources are extensively used, and that is why they are different from these public goods. But however, government can certainly regulate this problem. How? That government can pitch in and then increase the taxes, or say bring some regulation that okay fine, during this to this period in a particular hospital there will be free treatment, and beyond that period people have to pay charges, or just make some bring excludability for a certain section of the population, that those who are under this category, they will only get this treatment, so that reduces the load from that hospital. The rest they have to pay a general charge, or just turn the common resources, if it really doesn't improve, just slowly turn the common resources into a private good. But again, it is not really possible in case of the government hospitals or government health system in a poor country. That is not possible. So, or even in a richer country, when we talk about the universal health coverage, when we talk about the universal acceptability, the affordability, the building blocks, it's not really possible. So therefore, it's really a dicey situation for the government, that how to increase the efficiency when there is a tragedy of commons. See, the free rider problem can be mitigated, and maybe government is not really bothered about the free rider problem, but the common resources or the tragedy of the commons can really have a negative impact on the service delivery in terms of the health sector. Again, there is in health insurance market, this private good and public good are really two separate entities which coexist together. That is, the private health insurance are those for which you you have to make a voluntary payment, and you can customize your benefits, you get your benefits, you choose based on your preferences. And the private insurance players are very clear that you don't pay for these based on your preferences, based on your background. You don't pay for this, we are sorry, we cannot give you the insurance. Whereas for the public health insurance, which is a public good, there is no excludability, because it's most often it's mandatory, and then the contribution from the patient's part is very, very low. So there is no excludability, or as it is mandatory, it can be the contribution can be taken as for granted, that okay, we don't mind paying for that. And then the next one is there is no rivalry in consumption, because everybody who is potentially under the same category, they are supposed to get that those insurances, those social health insurances, or government provided health insurances. So the private health insurances and the government provided health insurances, their objectives are very different. And then in these developing countries where the health system is really turbulent and still finding its stability, there the private and public health systems are literally complement each other. Otherwise it's difficult for the government health system to continue or to achieve the complete or universal health coverage. That's because they don't have enough funds, they don't have enough coverage, and they once trying to reach to the poorest people, they cannot actually ensure that they are already spending so much that they cannot ensure the health insurance or the free services to the well-off section, and probably the well-off section can get their insurances or services from the private players in the market. So this is how it works. However, while floating a particular public good, or while floating a particular scheme, that whether the government will continue with that, making them a public good, or because after a public good, a particular commodity, with the utilization or realization of the benefits, maybe once the public good becomes the common resources, or maybe not having a lot of choices, so a public good now faces a lot of rivalry in consumption, a lot of patient fall. So if there is not many hospitals, so naturally in one hospital slowly people will start pouring in. So the government has to keep a track, that whether they will, because they are paying for that, and they have an objective, they have a goal, they have a target. So they have to understand that whether it is really the scheme, these policies, these plans are really working fine or not. So when they are launching a new public good, they have to keep a look on the vision. So first thing they do is that establish a vision. The next is do a situation analysis, that who will require, who won't require, by how much it is required, for which purposes it is required. Situation analysis, whether the children also require, or just their mothers require, whether the elderly is required, or only elderly women are requiring these benefits. So this is the situation analysis, so that they can design the plan properly. After situation analysis, they have an idea about the situation. So what they do, after situation analysis, they will do a financial assessment, because then they have to prepare the budget. So they do a financial assessment. After doing the financial assessment, then they will do the constraint assessment. They will do a constraint assessment. So once they do a constraint assessment, that means that once they are they are providing the funds, which are the constraints which may arise in the field when they are going for the implementation. So the there is required the constraint assessment, so that they can the next time they are or they have an additional budget if there is a problem, or the next time they are floating, they have a clear idea. So they will continuously do a constraint assessment while either before or during or continuously, they have to do this while during the implementation. And then they also need to figure out these constraints, if they arise, then there will be strategies. Which are the strategies for those changes? So which are the strategies they have to bring for these changes if there are constraints? So they have to find out the alternatives. Yeah. So next, after understanding these strategies for changes, now they are really confident about themselves that they can float this program and that can be successful. And there comes the implementation of this public good and or the public scheme. And finally, they have to do a bit of monitoring and evaluation, not a bit, actually a rigorous monitoring and evaluation, so that they can understand that the scheme there is moving towards the right target or goal based approach, or they are actually going to attain the what they have targeted. And then after monitoring and evaluation, they slowly establish, they complete the program, and then the final one is establish a new vision. Yes, after you achieve that, or even if you fail that, then what you do, you go back to do a situation analysis, that why you have failed. You do a situation analysis, and then you consider again that if we have failed, then again to manage that, or to attain the gap, to bridge the gap, what kind of financial assessment is required, what kind of constraints we have met across, and what could be the possible solutions, and so that this time we can attain the goals and targets. And this is how a government scheme or a public health scheme should work, or generally works. So thank you very much. So this is all about the public and private good in terms of healthcare. So the debate remains that whether the health care is a public good or a private good, and the answer often across the country is they are both. The public good cannot be all to attain the accessibility, affordability, quality in most of the developing countries, and similarly they cannot be private good. They must not be a private good completely. So they have to be a mix of both of them, so that it works towards the universal health coverage. Thank you.